session will be recorded, which you will see an immediate prompting right now about to appear on your screens that it's being recorded, but they're also being made available upon request. And if this interests you, to share for later reference or to share with other colleagues, please submit your request towards me at the email below at epenate@nm.org. Today gives me great pleasure to introduce Dr. Elizabeth Pierre. She is an assistant professor of pastoral care and counseling psychology at North Park University. She is also a licensed professional counselor. As I mentioned briefly, her research interests are in the area of care for sexual violence survivors and how contextual factors such as race, culture, and gender impact the experience of trauma and recovery. She has also worked as a counselor for women recovering from drug abuse and families going through the adoption process. Dr. Pierre holds a PhD from Garrett Evangelical Theological Seminary in Pastoral Theology. She also received her training in counseling from Boston College and the Center for Religion and Psychotherapy. She travels abroad to teach, to research, and to learn how to provide care in communities affected by violence. I'm very eager, very excited to welcome you here, Elizabeth, with our community. All right, the time is yours.
Thank you so much for your warm introductions. Here, the stop sharing. Do you want to continue? Okay, I'm waiting for you to stop sharing. Okay, there we go. Hello, everyone. Nice to meet you. Let me put my screen up here. Thank you so much for your warm presentation, Reverend Edward Peñate. And I'm just really glad to be here. Reverend Peñate has been very generous with his time, as I'm like, I want to make sure this is helpful for your students and for your fellows. And so we don't have a lot of time. I know that we have an hour, but hopefully you will see the intersection of my passions and the hope is that for you as chaplains, physicians, and whatever caregiving position that you're in, that you would get something where I think Reverend Peñate said this earlier, you'd be in a position to engage the Black community in a different way. And also there's gonna be some work around yourself too. So I do a lot of that myself, is making sure we're aware of our own self-awareness and how important that it is in our work as we engage with others. So hopefully it'll be a, fun learning experience, and that I would learn from you as well, and that it'd be a rich conversation together. Again, a couple of provisos. I kind of truncated everything within an hour, but I really hope that we do have some time for conversation, and actually we will earlier in our presentation. And if at any point you have any questions, feel free to put them in the chat and I'll try my best to answer them that way. But thank you for inviting me, and thank you that I get to join you for this part of the series. All right. So to begin, I just want to give a couple of definitions that will help us with our first couple of questions that I'd like to engage. And that is the term embodiment. And a psychologist out in California succinctly writes, embodiment involves the engagement of the body with the world, including the relationship between people's bodies and their social contexts. If there's anything you get from this presentation, that I would like it to be that you are aware or more conscious of how your body, your race, your culture, your sexuality all impacts the work that you do. And I'll share a little bit of story and how that happens personally, how that happened for me in my work. And then because I'm a practical theologian, I have to put this in here, that our communication is more than words. Our bodies convey a lived theology. Even if you don't have a particular faith or don't believe in a higher power, that's still impacting how you engage with others in your practice. So our bodies convey a lived theology. They're not maybe fully integrative with what we say or believe. Embedded values expressed through our bodies are shaped by our families, communities, and culture. often outside of our awareness. None of us are spirits at this time floating around. You see me, I'm a Black woman, but there's more to my story. I'm a Haitian American woman. I have a whole history that is not seen or understood just by looking at me. But you notice that I'm a person of color, and that matters, okay? You've done a great job already you've had great speakers who talked about spirituality. I had to put Pargament in here since he was one of the speakers. And he describes broadly that spirituality is an extraordinary part of the ordinary lives of people. In crisis and in catastrophe, spirituality is often intertwined in the struggle to comprehend the seemingly incomprehensible and to manage the seemingly unmanageable. Spirituality is not reserved exclusively for times of crisis and transition. It is interwoven into the fabric of the everyday. So it's just fundamentally who we are in essence. More succinctly, spirituality is also concerned with the transcendent, addressing ultimate concerns about life's meaning and purpose. And religion, spirituality, shared by a group of people, often with a common set of beliefs and practices. So wanted just to put these definitions out there because that'll help us move forward with a kind of a better framework to understand where I'm going and why I'm going the direction that I am. Okay, with that said, I have a couple of questions for you. It's good to know who's in the room. How have you seen your patients' experiences of embodiment and spirituality impact their end-of-life struggle? And what characteristics of your body and spirituality influence how you experience the world and how others experience you? So I would love just to hear from a couple of folks before we move on. It'd be good for me to kind of get a feeling of who's in the room. The floor is open.
Just this morning, I had an encounter with a patient who is in the ICU and knows that they are at the end of their life and specifically asked the question of me, knowing that I'm not a medical professional, what will that look like? What is it like at the end of life? What will happen to my body?
Yeah, wow.
It's the first time anyone actually approached me with that question, and it certainly gave me pause for thought. Okay. And to your second question, clearly I'm a white middle-aged woman, which means that people make assumptions about who I am when I walk in the room.
Thank you so much, Annette. That's really helpful.
Hi, I'm Denise from Northern California, and I'm just reflecting on visiting with a woman who was dying with multiple sclerosis. So, but that process of how the disease greatly impacted her body and how she was viewed by the world because she was not as physically able as other people. The pain of that, but the idea that in her Christian tradition that the bodies would be restored somehow in heaven really puts this it's the ability issue that people with disability are seen as less than people. Anyways, so just as she was reflecting on that, it's really, really powerful. Caused me to think about what are this vision of the afterlife or of heaven that we think about. And as similar to Annette, middle-aged white woman of size, I would add in there as well. Definitely that impacts how people perceive me. Sometimes it gains me greater access. Sometimes means less access to conversation.
Thank you so much, Denise. I appreciate, thank you too, Annette. And I want a couple of more people to, a couple of more voices, but I just want to respond to both of you that I've appreciated that the awareness, like remember in the definition there, oftentimes we're not aware of what our body means in a room. And even though we're like, it's sort of like, it's there, but unless someone names it, you're like, oh yeah, that's right. And we have these embedded theologies or embedded philosophies, ideas about the afterlife that maybe we don't name, but we believe, but affects how we engage with the other. And I was saying, I didn't realize that. Okay, I mean, for some people who are coming from the Christian faith, like I am, they do believe in it and in the afterlife. So like, thank God this body's going and I'm going to get a new body. But if you don't believe that, that might affect how you engage, not necessarily in a poor way, but it may also affect the kind of questions you ask or don't ask that might be helpful for your patient. 2 more, please. I'd love to hear from 2 more before we move on. Thank you again, Annette and Denise.
I have a story that kind of integrates your first question and your second question.
Sure, who? I can't see
I'm
you.
a hospice chaplain. I'm sorry. Now, Laura S.
Oh, hi, Lori. Now, yeah, you had frozen.
Yeah,
Yes,
yeah.
you're here. Okay, great.
I'm a hospice chaplain and we go into people's homes, and already we have a certain amount of personal protective equipment that we wear. And then in certain cases, we wear more. And a social worker and I were visiting a patient who had C. diff, which is a really, 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 really easily transmissible, nasty thing that gives you diarrhea and all these things. And so when you visit a C. diff patient, you put everything on, the gown, the gloves, the booties, the mask and everything. And we stood outside the home of this patient, and I said, you realize that this is a patient from an African-American background, and we're both white women, and we're going in there with all this PPE on. And they don't know that we are required to dress this way because the patient has C. diff, and let's be ready for that. And as soon as we walked in, the daughter said, do you think we have cooties or something? And so that was very much, it's one of those things I'm always going to remember about how my embodiment and my job interact with the embodiments and the conditions of our patients.
Yes. Oh, thank you so much, Laura. That's a rich story. Thank you. I think there was one more with the Peñate group. Thank you.
Yeah.
If you guys can't hear me, let me know. I can move closer to the camera. My name is Alex. I'm one of the Palliative Care Fellows.
Can you move a little closer, Allison?
Yeah.
I want to make sure everyone gets to hear your question.
Can you guys hear me now better?
Yes.
Okay. So for the first question, I have a patient that I've been seeing in clinic every month or so for the past 6 months. And I've watched her as she's gotten struggled more with being able to get out of the house and do things. And I've been listening to her struggle with these worsening fatigue and these limitations in her abilities. But in the same time, as she's been more limited physically, she told me the first visit that what she relies on is a prayer train that she does with her church community every Sunday. And during this time, she's talked more about how now that she's expanding her personal prayer train to doing it more days a week and replacing some of these physical activities she used to do with an element of her religion and spirituality, and utilizing her prayer train in something she feels like she is able to have more control over more frequently. And I've found that to be, it's hard to listen as she talks about her frustrations with her disease and her prognosis, but seeing her tell this like change in balance and how she's replaced it with another element of herself has been really powerful to see. For the second question, I'll start with saying I am a younger, I guess on the younger side as a trainee white woman. I don't always feel much younger, but I feel like that can impact sometimes whether or not some patients may or may not respect my opinion. On the flip side, some people say, oh, someone who finally I can relate to, you know what I'm going through. But actually, when Laura was speaking, I thought about one experience I had that I hadn't thought of before, is just with our white coats that we wear in our fellowship that say on this on the left, they say hospice and palliative medicine. And I had one experience where we came in for a patient who actually wasn't, they of course had a chronic terminal illness, but they were not actively dying by any means. We were brought in to help with symptoms, and they immediately saw me and said, hospice. We didn't ask for the hospice doctor. And that's experience allowed me to be a little bit more aware of thinking about even just the words that are written on.
Yes. This is, yeah, you ended this well. Thank you, Allison, because that for our time together is growing awareness of how all this means and how that affects interactions. Whether you're not paying attention, your patients are. So I'm gonna give you 3 quick stories before we move on to our time together. So my name's Elizabeth Pierre. Most people, and I'm in a clinical world, I'm a professor, I'm a therapist, I'm a researcher, and I see patients, clients, patients, and when they see my name, people are not usually aware of who they're going to get. Elizabeth Pierre can mean lots of different things. They usually think I'm French, but not probably a person of color. And so a couple of years ago, I had a client who came in, and people of color are aware of this, but I felt her kind of like, she was kind of surprised, but she was surprised that she was surprised, if that makes sense, that she saw me as her clinician. And for the first, I would say 5 to 6 weeks, she told me a lot about all the anti-racist work she was doing. And I thought, well, that's interesting. I'm sure, surely should not come for therapy for that. So I just paid attention. I noticed that our sessions were kind of lulling, and I'm very curious about people, love people, enjoy working with people. And I found myself getting a little sleepy, to be honest, during sessions. So I'm like, something is going on here that I need to figure out. So I talked to my supervisor, and we both realized that I think she's anxious that she was anxious that I was Black. She felt bad about it, if that makes sense. Like, oh my gosh, I'm doing all this work, and I was surprised. So finally, during one of our sessions, I said to her, I said, hey, you know, I'm okay with you being white. That's who you are, and that's fine. Let's get to the real work of why you're here. It changed everything. Just naming that, we got to the real reason why she was there. But it took her a while she was probably anxious about naming it, but here was both our embodiments were becoming an impediment to the work that was needed. And I had to name it. There's a second story where this young person came in, and they just kind of just brought everything. And they're like, listen, are you okay with LGBTQ people? Are you okay with biracial people? Or do you care that I don't believe in anything, because this is Center for Religion and Psychotherapy? They put it out there. They named everything that they needed to make sure we could do the work that was necessary. It was important to them that I held their embodiment in the way that that felt comfortable for them. And then lastly, there was an African-American client of mine who at first did not see me, but met with another Black clinician who had straight hair and fabulous woman, fabulous colleague, but that colleague told me, oh, I don't think this client likes Black women. And I'm like, well, that's interesting. But long story short, I ended up, because she was referred to me by another colleague. So it could have been too that she just wanted to meet me because I was referred to her. But long story short, this client also had natural hair. And there was a way she felt more comfortable with me based on who I was physically. Dark skin, natural hair person, and she just vibed with me in a different way. So it wasn't that she did not like Black women, but there was a particular kind of Black woman that she felt like she connected with more. And that affected our work together. And there were different other things too. 3 stories, 3 very different stories, but all showing the importance of being mindful of what we bring literally in the room that we need to be conscious of. Because my work is around sexual violence, I told Reverend Edward, we've got to bring this in, because given the statistics, most of your clients, especially clients of color, which we'll be looking at, women of color, have a history of sexual violence, which the research show may be impacting or exacerbating some of their symptoms, okay? So many of you know this. This is from, I think it was out in 2011, 2012 maybe, but a lot of these statistics fluctuate, but the gist is there are too many men and women who are being abused, okay? That's just it. So 1 in 5 women in the United States have experienced completed or attempted rape during their lifetime. Nearly 0.25% of men in US have experienced some form of contact sexual violence. 1 in 3 female victims of completed or attempted rape experience it between the ages of 11 and 17. And you're hearing more stories as people are on their deathbeds or recognizing that, you know, they only have a couple of months or a couple of years to live. Memories are emerging, and they realize that many of them, they have not shared this story that has impacted their lives. And then 1 in 4 male victims of completed or attempted rape first experienced between the ages of 11 and 17. So again, think of all the patients you have right now and look at these statistics. They have a history of trauma, whether or not they've mentioned it to you. It's just too much. And then there's a group of people we don't really think about, are older adults who have been sexually victimized. This is a recent study that happened in 2020 in Europe, where they they're recognizing the dearth of research in this area. We tend to focus on young women, particularly, which is true. There's a lot of trauma there, but there are also older adults who have been sexually victimized and often a neglected group, and are not often asked if not only do they have a history of sexual violence, but is it actually happening now, which could be impacting their health in other ways. So remember this group, they're also being affected, especially in nursing homes, okay? Back to embodiment again. Black women and Indigenous women have some of the highest rates of intimate personal violence. For every Black woman who reports rape, at least 15 Black women do not report. These are recent, 2021 and 2020. 1 in 4 Black girls will be sexually abused before the age of 18. 1 in 5 Black women are survivors of rape, and 17% of Black women experience sexual violence other than rape by any intimate partner during their lifetime. And then more than 20% of Black women were raped during their lifetime, a higher share than women overall. Sexual violence is insidious overall, but there are certain groups of people, Black women, Caribbean women, and Indigenous folks who are especially affected by this. And we'll talk about as to why. And I'm sorry, I should have said this earlier, given the sensitive nature of the material, please do what you need to do. If you want to close your camera or take a step away, I just want to make sure people are grounded and in good health as we are engaging this sensitive topic. Okay, my apologies for not saying that earlier. Trauma and embodiment. There are a lot of historical factors, such as physical and sexual exploitation of Black women that have actually been internalized. There have been stories that you've probably seen in the news, where Black women have been targeted primarily because they're Black women and or poor, and where they are sexually violated. And we're going to look at some of these. There we go. Some of these stereotypical images that I think it's really important for you as clinicians, as chaplains, as physicians to be aware of if you're not aware of them, because it'll help you posture yourself differently with Black women, particularly when as their patients. So here's some 3 stereotypical images that are historically have impacted Black women. The first one is the Jezebel, which basically Black women are seen as licentious, that they're just, always looking to be deviant, to have sexual encounters with folks. So that happened particularly during the slavery times. And then you have this notion of the strong Black woman, which basically the Black woman is indestructible, that there's nothing that you can do to her that can break her down. That is challenging when someone who is a patient of yours who is struggling and who's sick, who has to kind of muster up, like, I can't tell you how much pain I am because I am this SBW, I'm the strong Black woman. I don't want anyone in my family to know that I'm suffering. Many Black women don't tell other people in their family of a diagnosis because they want to appear like, listen, I got to hold this down. There are some positive to this because, Black women had to do over the years to keep their family together. But the negative of this is that Black women don't often get the help that they need because they are adhering to this stereotypical image. And then you have the mammy, the asexual Aunt Jemima. I don't know, we no longer have the Aunt Jemima syrup because that is what the stereotypical image is very detrimental to the view of Black women, because it just says, you know what, you're nothing there just to kind of be, there's nothing about you, about your embodiment that's attractive, that's beautiful. You're just all that you can do is serve our community, serve our family. So particularly in the times of slavery. So you will hear these in different ways, and these are being destructed by a lot of like womanist theorists right now to really challenge these different unhealthy stories. But just because they're being challenged doesn't mean that they're still not being internalized by our society and by Black women themselves. So to keep that in mind when you're caring for patients of color. And these also impact people's ability to disclose any of their sexual violence experiences, because it affects their ability to really share what's happened if they feel that this is what you think of them. So why am I going to disclose if you think I'm a Jezebel, a SBW, or a mammy? You might even not even think of my story as being something that is true. So again, you don't go around telling people this, but it'll help you hold, like, I wonder what the story is for this person of color. And maybe I need to kind of be mindful of the kind of questions I ask if this is part of their internalized message. And here just some more, again, some historically, Black women have been, this is the complexities for Black women, is that they've been generally viewed as property. They're objects of production. You just do things, you haul things, you just produce. You are the object of reproduction. You have babies so they can be slaves for us on the plantation. And then you have Black women as bodies of sexual violence, vulnerable and available to slave masters. At one point, Black women were not considered to be rapeable because they were seen as animals. So these are the messages, these are these ideologies that have been really, really deeply seeped in our system that are still alive and well today. And to be mindful of that as we care for patients, particularly women of color. I think this is a theologian who does a lot of work around sexual violence. And I just want to read this because I think this is really helpful for you as caregivers. It says, racism also contributes to the minimization of sexual violence against women of color. Some cultural attitudes view women of color as being less than Anglo women, specifically African American women or Latinas, naturally sexually promiscuous, i.e. the Jezebel, or Asian American Pacific Islander women as naturally obedient and subservient to men. These racist attitudes may cause society not to respond to the victimization of women of color. And I would also argue it really affects how women will disclose their history of victimization as well. So just kind of holding that sexual violence is deplorable all around, but to recognize that people of color, Black women, have multiple layers that exacerbates their experience of any type of violence, particularly sexual violence, and it also affects their recovery. As many of you know, trauma has an impact on the physical health. Many of you, the doctors, clinicians, chaplains, you're dealing with people who are sick. And if the statistics are true, which I believe they are, I believe that there are probably more folks who have a history of sexual violence than are stated. And what we know of the adverse child experiences, then who knows how much of your patient's issues, diseases have been affected by their experience of intimate personal violence. Because the research is showing more and more that ACEs or any type of sexual violence contributes to COPD, liver disease, cancer, that there's a connection there. And so also to be mindful of that. So trauma, hopefully you're starting to see all the layers. It's deplorable, but then for people of color, Black women, you have another layer of navigating their experience in this country. And then it also contributes to their physical health or lack thereof. So, as for regarding spirituality, I think we're going to go back to here. Spirituality, religiosity, historically and still, I forgot to mention, I don't know if I told Reverend Peñate this, but I also was a pastor for several years, so I've witnessed this, is significant for people of color. So historically, during the slavery times, my goodness, God was the only thing that you had, the person that you had who valued you on this earth. So the spirituals, the hymns, the prayers, the worship was what grounded people, is what was humanized people. And that is what is true till today. Prayer, worship, it's important to be mindful of how these are important coping mechanisms for your patients as they navigate trauma, as they navigate their diagnosis, which oftentimes is a traumatic event for your patients as well, is that they go to God, they go to their church community, they go to their mosque where they can get the support that they need. And I want to point out this too, the role of the Black church is significant. So if you have patients, Black patients, inquire about their support system. The Black church is not just a sacred place to worship, but it's where you get your education, it's where you get your financial training, it's where that you get support in ways that you can't get externally. And it's in one of the most recent research here on for HIV, people living with HIV, it was critical that faith leaders were involved in the psychoeducation about treatment. Some folks will go to their pastors before they will come to a therapist or a chaplain. What does my pastor say about this? What do my people in my community say about this before I say yes to this treatment? So I would encourage you, as you support your patients, inquire about their support system. For Black community, for the Black patients, again, I don't want to essentialize folks, but most likely their church, their mosque, or their spiritual community, it's going to be a vital, important part of their support system. And I would encourage you to see how that they may be involved so that folks don't feel that they're alone on their journey of recovery or any other kind of health ailment. Some more, particularly for Black women who are trauma survivors, again, spirituality has been a significant coping, culturally relevant protective factor. So if you have patients who have that history, inquire about their spirituality, inquire about their religiosity, and how is that making meaning for them as they navigate the recovery process. My research was actually particularly on sexual violence of Black women, and it was interesting because in some ways the church was not helpful, but their spiritual practice was what kept them grounded during their recovery process. Scripture, finding that there were other women in the Bible who were also raped. I'm thinking about one sample, someone in my sample who said, oh my gosh, I didn't realize that women were raped in the Bible. She was thinking about one particular story. I connect with this person, and it really just changed. She didn't feel like an anomaly. She felt like she belonged. So ways to kind of, whatever sacred reading that might be important for a survivor, inquire about it, because it's something that helps them navigate and that helps them navigate their recovery process. And inevitably, forgiveness. Erikson model of development. You know, you have your generativity and despair. When someone has found out they have a diagnosis or they're a victim of sexual trauma of some sorts, and they're a person of color, inevitably forgiveness is going to be a part of the process for them, and that's really important to know. Who do I need to forgive? Can I forgive myself? Especially if spirituality is such a significant part of their being a relevant, positive, protective factor. There's no way that forgiveness is not going to be a part of the process. And we're finding that forgiveness also impacts one's physical health. I want to be clear though, no one is forcing anyone to forgive anyone. Forgiveness is complicated. That's actually my new research looking at how forgiveness impacts trauma survivors. But it's important to be mindful as to how that is impacting their health and recovery when you are journeying with folks within this community. And for some people, maybe that's the final thing that they need to finally have peace with their life, or to finally to say, you know what, I can leave and die in peace. Or maybe there's some reconciliation that I need to do, not just with others, but with myself about what has happened in my life. So forgiveness and in partner violence, the research, again, it's inevitably, it's going to be a part of the process, but at their own time and at their own pace. Just to kind of keep that in your mind, again, for the people of color, Black women as well, if spirituality is a significant part of their protective factor, then forgiveness is going to be a part of their story that you can't ignore. So considerations for practice, because I really want us to have a conversation here, if we have time, which I believe that we do. I love this quote this is from a couple of doctors, a couple of years, it's a couple of years old, many years old, but I feel like it's really significant for our conversation today. And it says this: bearing witness to a patient's faith is often a therapeutic act, whether or not the physician shares these beliefs. If comfort is derived through the belief, the doctor can bear witness to this comforting nature of the patient's spirituality. And for the Black community, for Black women, and for survivors of Black women who are survivors of sexual violence, the fact that you're acknowledging the role of spirituality and also being mindful of the complicated nature of their experience is a gift. It's important to know your role. You're not a preacher. You're not, you're not a spiritual guru. You don't know all things person of color, but just being mindful is like, I wonder what the many layers are here is significant. And people of color, as a Black woman, I can know and tell when people are aware that I'm not this one single story. There's multiple layers to my story, okay? And this idea of being a witnessing presence, I think chaplains are probably are more aware of this kind of language. And this is from Shirley Rambo. She's also a theologian who's done a lot of work around trauma. And she says this: the experience of traumatic suffering is intensified by the invisibility and unspeakable nature of violence. A witnessing presence in trauma will make visible what is rendered invisible. If a person who survives trauma can put words to that experience, the process of healing can take place. And this is not just about sexual violence, but I also think, again, the traumatic experience of getting a diagnosis that, you may not recover or you will not recover, that your witnessing presence is significant, and being mindful of what it means to be in their body of color. And just being a witness to that, not needing to fix it, but holding all the complex layers of that can lead to a process of healing. Maybe not necessarily physical healing, but of healing where it can bring some people some peace. The complexities of trauma, and was reiterating the nature of it. There's so many complexities. And again, I refer to the single story by Chimamanda Adichie, who wrote Half of Yellow Sun. She does this great TED Talk, if you haven't watched it, about the single story, or the danger of the single story, is that when you have clients of color, Black people as your patients, to be mindful all the multiple layers of the experience. Even being a dark-skinned woman is very different being from a light-skinned woman. Do your work as clinicians, as caregivers, so that it won't impede the work, the good work that you do. Again, back to the witnessing presence, it's the essential first step to a traumatic recovery. Being that you don't underestimate the theology of presence, your witnessing presence as you care for people of color, Black women, especially given our context today, the importance of holding that, but also being aware of what your own body means, as some of you is already engaged. So here's just some things again. These are not to do, but it's a way of holding and being mindful of what your presence means, your embodiment means, and what the embodiment of your patients might mean with you. First one is to listen to your patients. Being attentive to the multiple and complex layers of trauma and spiritual layer for your Black patients, especially with the history of sexual violence. Again, given the statistics, think about all your clients and patients, and then think about all your patients who are Black, and they have a higher rate. That's part of their story, okay? Stay curious, inquire about spiritual practices that may assist them with coping. Prayer groups are huge for the Black community. Is that helpful? Who are the people you're praying with? Worship, music, hymns, spirituals. Is it helpful to put that music on? I don't know, but just stay curious about that and asking those questions and not making assumptions. Consider how forgiveness may be playing a role in the recovery of treatment. Listen, is this something that you're thinking about? Forgiving yourself, forgiving someone else, how that might be helpful for your recovery. Considering collaborating with faith leaders within the community to support with treatment. I think that's phenomenal. I'm all about collaboration. Who are the people in their community? Who are the people in their support system who might help you to get them into a healthier place? Some folks will not take medication if they don't get the support from their community and or pastor. And finally, being conscious of your own embodiment and how it may affect practice and interaction. Some of you have mentioned it already. It does. It really does. Do your own work, your reading, being more reflective about how you enter the room, what you're wearing, how you're saying, just being aware how all that shaped you, that you're not walking in without all of those values. I know for me as a therapist, I do my own work consistently as I have my spiritual director and my clinician that I see on a weekly basis to make sure that I'm coming with my whole self, but also being mindful of how that might impede the work that I do and staying open to staying curious about my patients and my clients and even my students. The more grounded I am, the more I embrace who I am, the good, the bad, and the ugly, the more I give space for my clients and my patients to be okay with who they are and in the body that they're in. And that's me for a nutshell here. So I wanted to give some time. So that was a lot, but I hope we have some time for conversation. Reverend Ed Peñate, I just wanted to, I don't know what else to do now, but stop sharing it.
No, you've done a lot. Thank you so much. And I'm here in company with others, and that's why I have my mask on here. But thank you, Dr. Pierre, for Elizabeth. It was very rich. It was a lot, right? It was a lot to hold up here, but also here in my spirit and my heart, right? And you have, for me, I can say for myself, you have paused me to think about many things, right? To think about the layers, right? The layers of a human, not just any human being, but consider the human population and the different experiences that human beings encounter in this world have been different, right? And also bridging that with our previous conversations with Dr. Pargaman and Dr. Fichette with religious spiritual struggle. And you mentioned this one piece. This is my takeaway. And I want to open this for further conversation here, but you mentioned this moment about at the end of life that memories will surface again. And lived memories. All of this is going on in such profound ways. And that can connect and prompt other things. And those other things can possibly be RS struggle, right? For people. And that's something to think about, right? That's something to think about and to consider as I accompany and understand people, right? I can go on, but I do want to open the time to conversation with our audience, with everyone else here, your insights, your reflections with the presentation today. What questions do you have for Elizabeth, but also for all of us to think about here? And I'll pause now.
I actually have a comment.
We have one
Coming
here.
from the corner. Hi, I'm Lori. I'm one of the palliative care fellows. Thank you so much for your presentation and the work that you're doing every day. I'm just still kind of thinking and reflecting on something you were just talking about at the end of the importance of presence and bearing witness. And it's just reminding me of earlier in the week, I was in clinic and was reflecting with my kind of supervising physician about, we had a patient who we had seen in the hospital and had helped her, we think. she went home and we were doing a follow-up clinic appointment, and she's just dealing with a lot of struggle, existential distress, and about how difficult it was to get that same feeling of presence and like bearing witness, because in the clinic it was a virtual appointment, and just how different it was, the kind of connection and support that we felt like we were able to give her when we were in the same hospital room with her versus through a virtual computer screen. And I'm bringing this up, one, because it's something I'm still kind of reflecting on, and at least naming, but also wondering if anyone has found things that are helpful, potentially in a virtual setting.
Anyone else? With this group, I know that there is this skill of excellent skill that we embody and we practice of silence, but I hope that we can break that silence to prompt conversation. Right.
My name is Riley. Thank you so much, Dr. Pierre, for your presentation. I do have one thing I can offer to the question that was just asked in the room. I found when I really do not prefer to do chaplain work virtually, and yet because of the pandemic, I've had several times where I've had to do that. And the best thing that I can offer, I've been learning recently about polyvagal therapy. I call it the polyvagal theory, and it just talks about ways that we can show presence through our faces. And so really just like having, I mean, the stuff I'm going to say is stuff you're probably already doing, but I just want to say that I found and gotten feedback that it's helpful just to like keep a warm smile, make sure that you're kind of like having either a neutral or a smiling face, and just looking at the camera in an engaged way, and just using your body language a little extra to acknowledge that you can hear what's happening. I found that somehow, even though I don't feel it the same way as a practitioner, that the people that I'm working with have told me that they can feel it from me. And in fact, right now, I can feel it from you, Dr. Pierre, while you're looking at me, just the way that you're engaging the conversation. And so I think it's sometimes it's hard to understand the impact we're having on the other, and it doesn't feed my spirit as much as a chaplain. I don't feel as good in the presence because I'm not getting to engage in person, but there is a way that we can still convey that through the camera just by making a little extra effort. So that's what I know. Thanks for letting me share.
Thank you so much, Riley. Anyone else?
Hi, Dr. Pierre. I'm Dana. I'm the social worker with the palliative care team. I'm one of the social workers. We have two, and I really, really appreciate the insight that you've given us in your presentation. It's so significant. And I used to work in an outpatient geriatric clinic and had many, many African-American women share with me their prior abuse and trauma. Some of them were able to move past it and said, I don't want to dwell on it. I'm already over it. But there were some, and I'm glad you pointed it out, that it really, really comes to surface when they're older and they're isolated, and when they are nearing end of life. It really comes back to them. And I appreciate all the insight that you've given us. But for the other practitioners on the line, for me, it was always part of the assessment to ask about prior history of trauma and abuse. But for somebody who's going in to meet a patient for the first time, how would you recommend posing the question so that it doesn't appear to be just another question that we're asking? Because it can be such a sensitive topic.
Thank you, Dana, for your question. Elizabeth, would you like to begin that response? But
Oh, sure. I thought she, oh, thank you, Dana. I thought she was asking everyone else. Oh yeah, thank you so much, Dana. they're different. This is where the back to the theology of presence and kind of, or with the witnessing present comes in. There are some assessments you can find, actually, maybe not online, but that there's a way that's very benign. Tell me, what was your childhood like? Were there any things that, that were hard or challenging for you? That's gentle, but you're not assuming. So like, any difficulties you had? Did you have enough to eat growing up, or did you have a place to stay? Like, and then, because they're all usually connected. It's sadly, any type of violence there, if you haven't had enough to eat, there's probably some neglect. Neglect makes you vulnerable to other stuff. So you can gather some just being very gentle. And some folks, you can feel from them whether or not they're ready for that. But if you can start with a benign question, such as, just tell me a little bit about your story. What was life like for you? What were some positives and challenges of growing up? And see what emerges. And then I think from there, you can take it, you kind of roll with it and see where they may go. But I would love
Thank
to
you.
hear
That's
others.
very, very helpful.
But there are others of you I'd love to hear too, what you guys, I can learn from y'all.
I agree, Elizabeth. I know that we have a multidisciplinary presence here of social workers, therapists, psychotherapists, physicians, chaplains. So I'd love to invite others to respond. And there's wisdom everywhere here.
Absolutely.
Yeah.
I think something I'd like to raise up is just that appreciation of leaning into in working with people with faith, particularly the Christian tradition, leaning into that scripture that actually where people can identify themselves within that story. And we had a talk the other day where it was raised that if there is a tradition of lamentation, like that if lamenting is allowed in a tradition, that actually allows for greater recovery. And so I just want to bring that back to what you said about sharing that story about the woman in the Bible being raped. So there's something about not spiritually bypassing, but going into deeper to the resources that we have got to be with people. So I just want to appreciate you and mention that.
Thank you, Denise. Thank you, appreciate that. Anyone else? We have someone in, Laura mentioned in the chat, I'm going to read it. When I worked at the VA, sometimes I would invite my patients to write their own lament psalm. Thank you, Laura. Anyone else? What questions? What insights? What surprised you? What discoveries did this prompt for you today? We have one here.
Thank you so much for your talk. One take home that I really liked in general with thinking of this topic and then just everything we do in palliative care is just that phrase of stay curious. And I feel like how much we can learn just by having curiosity and not letting that first layer that we get from someone be like, okay, that's enough. I've learned all there is to learn about that person. They've given me this aspect, and just continuing to dive deeper and ask more, and just keeping that curiosity as we approach patients, both as in their illness and as people as in general. I like that as a take home phrase.
Yeah. Elizabeth, you're on mute.
Saying that I got that from one of my good friends who's also a colleague. I'm like, yeah, you're right, Melody. Yes. So I'll tell her that too. So I'll pass that on.
Yeah.
Thank you so much. My name's Kristen. I'm the Pediatric Palliative Care Fellow for this year. Thank you for your talk. I think one thing I've just been pondering on as well is, in addition to ourselves and our patients and the way that our embodiment and spirituality may impact our interactions, I also have been thinking about it in the sense of our interactions with other providers and other team members as well. And how there's a lot of different layers to what we all do, and someone's response in that moment may be much deeper than just whatever that exact situation is that's happening at that moment. It may be because of you know, like you're saying, the background and events that have impacted us moving forward. So thank you so much.
Mhm. Thank you. Yeah, it's really good. There's so many layers. I love saying that word, but it's true. And staying curious to that. And I think that we can never go wrong with just staying curious, recognizing that back to the Adichie comment about not having a single story, and staying curious about ourselves too. Like, what's going on with me, and doing constantly, you all are doing such important and significant work, and you're holding so much, i.e. you probably have experienced a lot of vicarious trauma given the work that you do. So grateful for all of you. So it's so important to really, I can't say it enough. I say this all the time. Your patients, your clients are not more important than you are. They're just as important. So please really do your work and care for yourselves, because you're the one accompanying and journeying. So the healthier you are, the more aware you are, the better it is for them too, because you're mirroring that to them.
Thank you, Elizabeth. I saw Pamela have her hand raised, and I'm wondering if she wants to offer a comment, question.
I just wanted to thank you for lifting up that there are nuances to being a Black woman. As an oncology chaplain, I walked in a room one time and there was a darker skinned Black woman who had lost her hair. And for me walking in with my natural hair, which is 3A, 3B, versus someone who has 4C hair, it was an interesting exchange, but I do thank you for lifting that up, because that is real amongst Black women, and just among Black women in general. We're not monolithic in our existence, and I definitely applaud you for bringing that up.
Thanks, Pamela.
Wow, Elizabeth, thank you. We leave not going as experts, but really you laid the groundwork, the seed to prompt further reflections and conversations about this topic. This is not just to mark the checklist, right? But this is a clinical reality that we will face as practitioners in the healthcare setting, right? And thank you so much for being with us, for being our group, and really prompting reflection, our growth, and so that we can continue caring for ourselves and caring for others. Yeah.
Absolutely. Yeah. Thank you so much for letting me join you all. It was a real gift. Thank you.
Thank you.
Right. Thank you.
Bye, everyone. And I leave saying that these sessions are recorded. So upon request, you can email me so that I can send those to you. Okay. Thanks for joining us.
Thank you.
Thank you.
Thank you.